Hello friends, welcome back to my channel. Today we would be talking about upper respiratory tract infections part 2, in which we would be talking about larynx and associated infection of larynx like epiglottitis, croup and the parapharyngeal abscesses. Starting with laryngitis. Laryngitis can be both acute or chronic. We won't be discussing a lot about chronic, in which there is sign and symptoms of more than 3 weeks, and the usual cause is vocal abuse, so the treatment which is preferred is to give vocal rest. Talking about acute now, acute can again be due to vocal abuse, allergy or chemical burns due to inhalation or aspiration, or even sometimes due to endotracheal tube intubations. Or the etiology can be viral, in which we have influenza, we can have parainfluenza, the coronavirus, etc. Sometimes it can be bacterial, including your strep pneumoniae, Haemophilus influenza type B, beta hemolytic streptococcus, or exanthematous fevers. Exanthematous fevers are fevers which present with rash. They can have as a symptom your laryngitis, or patient would obviously say that the patient has sore throat. Each one of us have had laryngitis in our life. So exanthematous fevers like measles, chickenpox or whooping cough also known as pertussis. The clinical features are, as we have all experienced, hoarseness of voice, pain in the throat, especially while talking. The main thing to remember is that whispering should not be done, as it would cause even more pain, more damage to your vocal cords. Instead, try to talk in your normal voice and do not try to whisper or speak in a lower voice. Then we will have dry cough, as we all know. So the treatment would obviously be vocal rest, antibiotics, analgesics to relieve the pain, steroids. Now, when are steroids given? Steroids are given in case of chemical burns and steam inhalation. Why steam inhalation is given in this case? Because on examination, the vocal cords would be edematous, and there even maybe a stringy discharge present in between them. Stringy sticky discharge is present. The vocal cords are quite inflamed. They are earlier stages they are white in color, white and swollen. Later on they turn into red and swollen with sticky discharge. So steam inhalation is basically to liquefy that discharge. So laryngitis is a short topic, mostly not asked in our question papers or anytime, but for when we are in third year or as a general rule, we have to remember that whispering is avoided and we should talk in our normal voice. Then talking about epiglottitis. Epiglottitis is also known as supraglottic laryngitis. So friends, larynx is divided into 3 parts: the supraglottic part, the glottic part, and the subglottic part. Knowing about the details is beyond the scope of this lecture, but we should remember the type of stridor produced, which would greatly help in our clinical practice to differentiate that which part is actually affected. So in supraglottic part, we have an inspiratory stridor. That means the sound would be produced when the patient is inhaling. In the glottic, we have a biphasic stridor, that is, even while inspirating or while exhaling, both times the sound would be heard, and it is a very deep sound. You just cannot miss a stridor sound. In the in the subglottic, we have an expiratory stridor. So from this, we can see that in epiglottitis or the supraglottic laryngitis, there would be an inspiratory stridor present. Now, all the parts, not just the epiglottis but everything in the supraglottis is inflamed. So epiglottis along with the epiglottic folds and the arytenoids. The main point to remember is that epiglottis is an unpaired elastic cartilage. So the main thing to remember is that epiglottis is an unpaired elastic cartilage, whereas arytenoids are your paired cartilage. The larynx is made up of 3 paired and 3 unpaired cartilages, again beyond the scope of this lecture, but just giving you an idea. So what happens? The epiglottitis basically occurs in children of age 2 to 7 years, most commonly caused by Haemophilus influenzae B, type B. But as we all know that in the pentavalent vaccine, we now cover Haemophilus influenzae B, so the epidemiology of Hib infections are decreasing, but again we can have infections due to either Streptococcus pyogenes or Streptococcus pneumoniae. It is usually of an abrupt onset and progresses rapidly, so early intervention is required. The patient would present with dyspnea, sore throat, dyspnea or stridor basically occurs in children. We just talked about that if supraglottis is involved, then the stridor is inspiratory. So in children there would be dyspnea, there would be stridor, whereas in adults we basically have a sore throat or dysphagia associated with fever or septicemia. Now the point to see is that as fever and septicemia, there is septicemia, so we can draw blood cultures, and blood cultures are usually positive in this case. Nonetheless, the diagnosis should be mainly clinical as it is an emergency and we need early intervention, and we should never ever swab the epiglottis. Why? Because if you take a swab from the epiglottis, then it can lead to respiratory obstruction. Blood culture is positive as we see that there is septicemia. The treatment would be third generation cephalosporins. For example, your ceftriaxone. We can add vancomycin along with it, but the foremost thing to do should be to manage the airway and to do a tracheostomy. Don't put the endotracheal tube or anything to cause a snap or the respiratory obstruction. Do a tracheostomy. Radiological correlation would be that normally this is how our epiglottis looks like on a lateral x-ray, but as the epiglottis is swollen, it looks like this. So looks like an impression of a thumb, so it is known as the thumb sign. It is often asked in your NEET exams. Short question to be asked. Then we have, moving on from the epiglottis, we have laryngotracheobronchitis or Croup. As the name suggests, it involves larynx, trachea and your bronchi. The best mnemonic to remember Croup is by Crops. You can never ever forget about Croup if you remember it by the mnemonic Crops. It occurs in children of age 3 months to 3 years, differentiated from epiglottitis, which was occurring in children of age 2 to 7 years, that is school-going children. Here the child would be usually in the care of the mother because 3 months to 3 years. And the main thing, it is caused by parainfluenzae type 1 and type 2, whereas your epiglottitis was caused by Haemophilus influenza type B. The patient would present with a characteristic seal barking cough. As it is below the larynx, the trachea and the bronchus are also involved, so an expiratory stridor is seen and the subglottic portion is involved. There would be a stenosis, so the patient would land up into respiratory obstruction. How do you manage this patient? We manage the patient, by hospitalizing. We give a lot of IV fluids. We give the patient corticosteroids to decrease the inflammation. We give racemic mixture of adrenaline, and of course we have to maintain airway. We have to give patient oxygenation, humidification. On the x-ray, the characteristic sign is a steeple sign. Steeple sign, that is the like church hota hai. The ending of the church is somewhat like this, so this is known as the steeple sign. This is the steeple sign. So this is characteristically seen, and again a short question. Steeple sign is seen in, thumb sign is seen in. So epiglottitis, thumb sign, croup, steeple sign, very important, must to know. Sometimes they ask you the differences about between epiglottitis and croup. So remember, age 2 to 7 years epiglottitis, 3 months to 3 years croup. Both the treatment is same: corticosteroid, racemic adrenaline, oxygenation, hospitalization, IV fluids, antibiotic, and so not antibiotics, sorry. That is caused by Haemophilus influenzae. Croup is caused by parainfluenzae. Sometimes in croup we see there is pulsus paradoxus. It is sometimes asked in medicine that okay, pulsus paradoxus is seen in all in croup, what type of pulse is visible. So that is pulsus paradoxus. In radiological, in epiglottitis we have the thumb sign. In croup we have a steeple sign. Now talking about the parapharyngeal infections. So parapharyngeal infections, we have two things: quinsy and Ludwig's angina. Quinsy basically is your peritonsillar abscess. So in tonsillitis, we saw the structure of tonsil. So this was the tonsil, the parenchyma, and the parenchyma had crypts inside it. Now the tonsil has an outer capsule, a vein. Let's see it in this image itself. So this is the tonsil parenchyma, this is the capsule of the tonsil, this is the supratonsillar vein, and this is the superior constrictor muscle. So in between the superior constrictor muscle and the capsule of the tonsil, this region gets filled with pus. How? The crypts, usually the crypta magna would explode and pus would get filled in this region. This occurs unilaterally, and there is such a big swelling that your uvula would move to the other side. The uvula is present like this, it would move to the other side. This is characteristic feature seen in quinsy. When you examine it, it would be completely red from inside the tonsil. The pillars would be red, the uvula would be deviated to one side, and outside it would be very warm to touch. The patient would have a swelling. Now it is usually seen in adults and caused by either your strep viridans, which are your alpha hemolytic streptococci. One question is often asked that how do you differentiate strep pneumoniae from strep viridans? Both are alpha hemolytic. Strep pneumoniae and strep viridans, both are alpha hemolytic. So they usually ask you how do you differentiate it. So what we do is we place a disc of optochin. If it is optochin sensitive, that it is streptococcus pneumoniae. If it is optochin resistant, then you say that this is strep viridans. How is it seen in a plate? If this is my agar plate, so pinpoint colonies would be seen. I'm making it as green because alpha hemolysis is usually seen as green discoloration. And if I place a disc of optochin. So in case of Streptococcus viridans, there would be growth around this optochin disc also, whereas there would be a zone of clearing in case of Streptococcus pneumoniae. So any zone of clearance would be regarded as sensitive in case of optochin disc. So strep pneumoniae is optochin sensitive, alpha hemolytic. Strep viridans is optochin resistant, alpha hemolytic. Then we have the beta hemolytic strep pyogenes. Strep pyogenes, which is your group A streptococcus, beta hemolytic streptococcus. Group B beta hemolytic streptococcus is strep ehrlichia. It can be again be due to Fusobacterium necrophorum. We discussed about Fusobacterium necrophorum in the last lecture, so kindly write down in the comments whatever you remember about this bacteria, one important bacteria, or the cause of quinsy can be your Staph aureus. We all know it is a very notorious bacteria. The clinical features would be fever, a sore throat, or rhinophagia, because obviously the tonsil is so much swollen, it is red, inflamed, your posterior pharyngeal wall is inflamed, the pillars of the tonsils are inflamed. The characteristic sign to remember is the hot potato voice, which is thick and muffled voice. It occurs जब ऐसे we eat a very hot potato or any hot vegetable, so we do the sound, so this sound comes out. Earache, we talked that earache can also occur in case of tonsillitis due to referred pain from cranial nerve 9. Trismus is rocking of jaw as the superior constrictor muscles lie close to pterygoid muscles. We have to remember this from our anatomy. What would be the treatment? We do an incision and drainage, and we give antibiotics. Usually in an empirical therapy we give piperacillin tazobactam combination. Tazobactam, as we know, is a beta lactamase inhibitor. So this would cover basically your gram positive, gram negative bacteria. So an empirical therapy is given. We can also send these, if the pus is drained, we can also send it for culture, do an antibiotic sensitivity testing. So this is about quinsy or the peritonsillar abscess. Now talking about Ludwig's angina. So Ludwig's angina is a diffuse cellulitis of the submandibular space. Now what is the submandibular space? This is basically a space between your deep cervical fascia, the superficial layer of the deep cervical fascia, and the mucous membrane of mouth or tongue. So I have tried to draw it just to give you guys a visualization. My drawing is not good, but this is just a rough diagram. So we have the tongue. This is our mandible. The mucus, below the mucous membrane of the tongue, this complete is your submandibular space. Obviously in the submandibular gland lies in it. So one of the etiology can be that if there are stones in the submandibular gland, then it can cause obstruction and lead to an infection in the space. The tooth also get inserted. This is not a tooth basically, but I'm just telling you guys that it can be due to your dental infections, basically your molars or your premolars. So the space is divided into two by the mylohyoid muscle. Again, a question asked as an MCQ, into two parts, sublingual space and the submaxillary space. So the mylohyoid muscle divides your submandibular space into two, the sublingual space and the submaxillary space, and the submandibular glands rise into the submaxillary space. What can be the etiology which can lead to infections here? If are there dental infections, maybe due to an early extraction or improper extraction, not maintaining a good hygiene, or if there is any stone in the submandibular gland known as adenitis, or if there is any injury to the oral mucosa, or there is fracture of the mandible. So this infection would usually be polymicrobial and anaerobic. Again, talking about anaerobic bacteria, we have our fusobacterium, which we have talked a lot, then Prevotella, the Peptostreptococcus, or the Porphyromonas. We would be talking about Prevotella in detail because it is a pigmented bacteria, and sometimes a question is asked which species give which color. So we would be talking in detail about Prevotella in later lectures. Another cause can be your alpha hemolytic streptococci, which is nothing but your viridans group, as we talked earlier. Bacteroids are again anaerobic bacteria. This is an emergency. Why? Because if there is pus filling here in this space, if we have pus in this space, then what it will do, it will push the tongue upwards, and laterally the tongue would be pushed upwards, causing airway obstruction. So we have to intervene as soon as possible. We have to manage the airway. How would you manage the airway? You manage the airway by doing a tracheostomy. Do a tracheostomy as soon as possible. Then go to other things like, do an incision and drainage, cover it with antibiotics, maintain hydration, because patient would have so much of odynophagia that literally the saliva would be drooling out. The patient would not drink anything, patient would be severely dehydrated, even the saliva would be drooling out. There is so much of pain that the patient cannot even swallow its own saliva. So do a tracheostomy, give patient IV fluids, do an incision and drainage, give the patient a broad spectrum antibiotic. And if we talk about the signs, then the patient would have this tender region. There would be a lot of tenderness. It would be red, it would be tender, it would be swollen like anything. And the characteristic thing is it has a woody hard feeling. If you touch it, it would feel like that you're touching wood. It is so hard. So remember all this about parapharyngeal abscesses. We have talked today about laryngitis, epiglottitis, croup, and the parapharyngeal abscesses. I have kept it very, very short. If you guys have any doubts, ask me in the comments below. If you want me to talk further about these topics, I can make a separate video to give more correlations. Kindly do like, share, and subscribe to my videos. Thank you so much.